in the Department of General Medicine. He had a history of hospitalization 2 years ago for severe headache and seizures. On MRI brain that was ordered there, he was diagnosed to have cerebral venous sinus thrombosis with hyperhomocystinemia. He was treated with oral anticoagulant, 2 mg every day, which he took for 4 weeks and then stopped it himself because he thought that he was cured. 3 months ago, he complained of right-sided facial weakness. There was ear discharge, also hearing loss, for which he consulted an ENT physician. He was treated for suppurative otitis media and lower motor neuron facial palsy with antibiotics and acyclovir. The ear discharge stopped completely, his hearing improved, but there was still residual drooping of the right side of face. No history of previous same episode, joint pain, rash, no history of any animal exposure, no past history of tuberculosis, diabetes, hypertension and asthma. The patient is a vegetarian. There was a history of weight loss, approximately 6 kgs in the last 6 months. His sleep was normal and he was sober. So, when we saw the patient, he was lying in a supine position, he was coughing repeatedly and he visibly looked anxious. Pallor was present, there was no clubbing, cyanosis, icterus or pedal edema, no peripheral lymphadenopathy and fundus examination was normal. On examination, his saturation was 96% on room air, pulse was 106, BP was 104 by 76, he was febrile, 100.1 degrees Celsius and he was tachypneic. Right, occasional infrascapular crepitations were present with bronchial breath sounds. Rest all areas had vesicular breath sounds. Cardiovascular and abdominal examinations were normal. On neurological examination, there was drooping of right angle of mouth and he was unable to close his right eye completely, but the taste sensation was intact. Rest examination was normal. So, considering this history and examination, we ordered a chest X-ray on day 1 of admission. As you can see, there is a right lower zone consolidation which is progressing towards the periphery of the right lung. So, now I would like to ask my colleagues, when you receive a patient with such a history and examination, what are the differentials that come to your mind? Anybody?
According to the history, it can be lower lung pneumonia.
Okay, yes.
Bacterial or fungal infection.
Right. Okay, that's one. Anyone else?
Can be tuberculosis.
Yes, that is the most common in India. Definitely. Okay, yes. Anybody? Right. So, when we think of right lower zone consolidation, what are the differentials that come to mind? First, tubercular, fungal, considering the long history, could be superimposed bacterial or atypical. Also, non-infective causes like aspiration pneumonitis, the patient was coughing repeatedly, could be pulmonary embolism considering the history of hyperhomocystinemia. It could be foreign body impaction. Also, it could be bronchial carcinoma or adenoma. Okay. So, routine investigations were sent and the patient was started on treatment which included piperacillin and tazobactam and clarithromycin. So, on the day 2 of admission, investigations came in and the CBC was suggestive of leukocytosis and neutrophilia. Serum electrolytes showed hyponatremia. Liver function tests were slightly elevated with AG ratio normal. Renal function was normal. ESR was significantly raised, 120, and lipid profile except all parameters was normal, which was abnormal was HDL cholesterol was 39. COVID RT-PCR was negative, urine routine was absolutely normal, and PBF showed normocytic normochromic RBCs. On day 3 of admission, the patient became more tachypneic and restless. His vitals were, saturation was 96% on 2 to 3 liters of oxygen. He had to be started on oxygen. Pulse was 110, BP was 134/92 and he was more tachypneic. On day 3, another set of investigations rolled in. CBC now showed reduced leukocytosis, neutrophilia was not there. ESR reduced to 96 from 120, CRP was 16, hyponatremia had resolved, serum homocysteine was 12.8 which was normal. D-dimer though was 2170 and LFT had also improved. Sputum for AFB, no acid-fast bacilli seen. Sputum for gram stain, gram-positive cocci seen in pairs. Sputum for KOH, no fungal element seen. Cultures showed mixed bacterial flora growth on culture and blood culture was polymicrobial growth. Rest everything was normal. So, as we can see on the screen, from the admission to the day 3 of the X-ray, now the right lower zone consolidation has totally covered the periphery of the right lung, and looking at the radiological deterioration, we immediately ordered a CECT thorax. Now I would like to invite Dr. Neha Sharma from the Department of Radiodiagnosis to tell us more. Good morning everyone. This is the HRCT scan of the patient showing axial sections in the lung window.
So Neha, can you first talk of the chest X-ray? What additional information you get on the chest X-ray? Yeah, both the chest X-ray. What do you see in this? What are the inputs for the non-radiologists?
So we can see a patch of consolidation in right lower lung zone. Along with in the day 3 X-ray, we can see right CP ankle is blunt, so there's mild right pleural effusion, and the mild lung volume is reduced. This is the HRCT scan of the patient showing axial sections in lung window. In the lung window, we can appreciate the lung parenchyma and its pathologies in good resolution. In the first 2 images, we can see multiple nodular lesions are seen in apical segment of the right lower lobe with central cavitation as marked by the arrows. In the below 2 images, we can see a large area of parenchymal consolidation in right lower lobe, which is associated with mild reduction of right lower lobe, volume of the right lower lobe. In further images, we can see multiple nodular lesions with areas of central cavitation on the left lower lobe also and inferior lingular region. The same findings are seen on the coronal and sagittal sections, suggestive of right lower lobe consolidation, and multiple bilateral pulmonary nodules with central cavitation are seen. On contrast enhanced axial images, in the first image we can see a lymph node which is located anterior to the trachea, suggestive of pretracheal lymphadenopathy as marked by the red arrow in first image. In the second image, we can see remarkable lymph nodes in bilateral hilar regions, so measuring approximately 12 to 13 mm in size, suggestive of bilateral hilar lymphadenopathy as seen in the second image. In third image, fluid density is seen in the right pleural effusion, suggestive of mild right pleural effusion with minimal basal atelectasis. And in the last image, finally, we can see a heterogeneous grade density area in the right lower lobe with central hypodense areas of necrosis. We can also see air trapped in the bronchi, suggestive of positive air bronchogram sign. However, no bronchial cutoff sign was seen. So our findings are suggestive of patchy consolidation with internal areas of necrosis along with multiple cavitatory pulmonary nodules which are diffusely seen in the bilateral lung parenchyma. There is predominant involvement of the mid and lower lung zones with some of them showing cavitatory lesions. The bony thoracic cage and chest wall are normal. Visualized part of upper abdomen also appears normal. So based on these radiological findings, our differential diagnoses are infective etiology, which can be fungal or tubercular, though tubercular is less likely as no green bud appearance was seen. Secondly, right lower lobe malignant lesion with bilateral intrapulmonary metastasis, and another differential can be autoimmune causes like SLE and vasculitis, as they can also show variable chest appearance. Thank you. Thank you, Neha. So, moving on. Now I would like to ask another question from my colleagues. Now that we know from the CT findings that we have multiple cavitatory nodules and the history and the examination, what are your differentials now? What does come to mind? Anybody? Yes?
So given the history, which is fever with chronic cough with hemoptysis, the first thing that comes to my mind could be pulmonary tuberculosis.
Yes.
But given the high ESR, loss of weight, we can also think of some malignancy like a bronchogenic carcinoma.
Yes.
And there's also, given the cavitatory lesions, there could also be some autoimmune.
Yes, very astute observation. Thank you so much. Now, what we considered was there's pulmonary tuberculosis, the commonest in India. Though atypical pneumonia, now it seems less likely as we have given the required coverage, and also the presentation seen here is not a common presentation of atypical pneumonia, so it's less likely. Fungal pneumonitis. Fungal is also less likely as the sputum for KOH should not reveal any fungal element and the patient was rapidly deteriorating. So, autoimmune disease, systemic lupus erythematosus was considered because there is a multi-organ involvement. anti-GBM disease or systemic vasculitis because there was a history of hemopsis. Also, pulmonary embolism. It doesn't seem likely. Why? Because the CECT has already ruled that out. Sarcoidosis. Sarcoidosis was considered as the patient had a history of Bell's palsy and there's bilateral hilar lymphadenopathy. Also, antigenic stimulation is possible. What is that? It is possible that the patient had a history of tuberculosis but did not know about it. So, sarcoidosis could have been stimulated. Aspiration pneumonitis is also less likely. Bronchial carcinoma with mets? Yes, definitely, that's a possibility. So, considering all our options, we started patient on anti-tubercular drugs because his liver enzymes.
Can I ask you?
Yes, sir.
Was a bronchoscopy contemplated or done in this patient or no?
Yes, sir, it was.
So you're going to come to that later?
Yes, sir, definitely.
So you started ATT before the bronchoscopy?
Yes, sir. Because the evidence was not there, but it was started on clinical expertise. Why? Because
Empirical basis.
yes, empirically.
Can I ask a question?
Yes, sir.
From the radiology people, how often do you see peripheral nodules like this in tuberculosis?
So very
Okay.
rarely. Not very common. Not very common.
My
Seeing this
question
CT
is
scan appearance.
when the radiological picture is not classical of tuberculosis,
Yes, sir.
and we haven't done the next possible investigation, which is bronchoscopy and BL and all those things.
Yes, sir.
Is it a correct decision to start the patient empirically on ATT?
Sir, actually, as evidence suggests, no. But because the patient was deteriorating, so this was the step that was taken on to start him on empirical treatment.
Yeah, and considering the real commonality of the disease and the pressure you are sometimes on at the bedside to do something, it sometimes does happen.
It will show its effect at least for 2 weeks.
Yeah,
Yes, sir.
correct.
Pathology.
Yes, sir.
So,
Sputum, yes, sir. We'll show that later.
Did you consider vaginal granulomatosis in this patient?
Sir, yes. It was considered systemic vasculitis was one of the possibilities.
That's a long list of conditions that we
Yes.
call systemic vasculitis.
Yeah.
That's a pathologic term, not a specific.
Right, sir. It was one of the
Vaginal
differentials.
would be one of those.
Yes. So ATT was added, and because the liver enzymes were raised, so pyrazinamide was withheld. Day 5 of admission, despite inhaled oxygen support, he continued having severe coughing episodes, and since the last 2 days, he started to report that he was feeling some hoarseness in his voice. At this point, his vitals were, saturation was 95% and the oxygen was 5 liters, pulse was 113, BP was 140/86 and he was very tachypneic. So, as you can see here, since the admission from day 3 to day 5, consolidation has spread and is now encroaching the middle zone of the right lung as well. Considering the radiological and clinical deterioration, we consulted with the Department of Respiratory Medicine. So a respiratory medicine consultation was sought to discuss further management of this patient. Now I would like to invite Dr. Mahesh Mishra sir, Professor and Head of the Department, Respiratory Medicine.
Now we have a background of young man having consultation, having intractable cough, troubling to the patient. We review the case thoroughly, right from the beginning, history, examination, investigation, all the things were reviewed. What is unusual that consolidation is very uncommon in young men. It is common in the extremes of age, older age or infantile age. Second things must come to our mind. The parenchymal disease do not cause intractable cough until unless there is endomucous involvement. First things we examine the patient again. What we found that hereditary was decreased in the right infrascapular and inframural region. Along the vocal resonance was decreased in the same region. Though this was against consolidation. Because in consolidation we found bronchial budding along the vocal resonance, increased vocal resonance. So we decided to look on the airways. So bronchoscopy was planned. Since patient was very sick, everything kept ready to even some eventuality occurs during the bronchoscopy. We did the bronchoscopy on the same day. What is This is the bronchoscopy picture. Though bronchoscopy was challenging, but we decided to take a challenge after assessing risk versus benefit ratio. We did the bronchoscopy. Because patient was of 5 to 7 liter oxygen, when we introduced the bronchoscope, situation further down. So bronchoscopy was challenging. However, we take it. No sedation was given to the patient because already patient is respiratory compromised, so we avoid sedation. We did it purely under local anesthesia, that is Xylocan. What you saw in the bronchoscopy? There is some residual lesion above the vocal cord. Movement of right vocal cord is less compared to the left. You can see this is a view of trachea, severely inflamed, hemorrhagic. You can see both bronchial tree, right as well as left, are severely inflamed. This is the left bronchial tree. You can see severely inflamed mucosa with some bleeding coming out from the left bronchial tree. This is right upper lobe, severely inflamed. You cannot enter in the right upper lobe. Right middle lobe is completely blocked. You cannot negotiate bronchoscope further. So we took biopsy from the right middle lobe and came out. After seeing endobronchial picture, we gave a shot of steroid inside the bronchoscopy room and procedure completed safely. No event was occurred during the procedure. After giving the steroid, just with the private team, show them pictures. We give the steroid and shifted back to the ward.
Any biopsy of the vocal nodule? No.
We didn't take vocal biopsy. Because handling of bronchoscope for the vocal nodule is very difficult. There is no control on the both difficult other than upper airways biopsy for the bronchoscope very difficult.
So, what was the bronchoscopy's impression of what?
Inflammatory.
Simple inflammation.
Inflammatory, severe inflammatory disease.
Could be bacterial, infective, could be autoimmune.
Yeah, it's more like what the autoimmune. That's why we give the steroid.
Inflammation is inflammation. So how did the bronchoscopy help us in refining our possibilities of the diagnosis?
So we took the bronchial lavage.
Biopsy on a lavage.
Yeah, we took the biopsy. And we took also bronchial lavage. We were sent for the various investigations to put the measurement.
So may I suggest that when we show videos, we edit the videos and show only the relevant clips.
It was only 3 minutes. It was only 3 minutes.
I mean,
It was 15-minute process.
It could have been made into 30 seconds and only the relevant parts could be shown.
The relevant part है sir. Relevant कुछ
नहीं, पर इसमें जैसे वो wash कर रहे हो आप blurred है, it could very easily be edited. Just a suggestion.
Screenshot of the biopsy being taken. Okay, so our patient was given a shot of IV steroid in the procedure room, and it was continued after discussion with respiratory medicine. On day 5 and day 7, as you can see, the consolidation is starting to thin out from the peripheries. So then we received the bronchoscopy report. It was suggestive of inflammatory pathology. So BAL was sent for gram stain, culture and sensitivity, fungal AFB smear and TB PCR with histocytology. Okay, so after this investigation, what are your differentials now? What can you think of? Anybody? Are there any ideas? Okay, moving on. So what do we have on our hands? We have a multiple cavitatory nodular lesions, consolidation, plus bronchial hemorrhage, plus minus CNS involvement. So, what can we think of? Pulmonary tuberculosis, yes, it's still a possibility. Nocardiosis, Lyme's disease, autoimmune disease. Why have systemic lupus erythematosus? There is bronchial hemorrhage, so anti-GBM disease or systemic vasculitis. Sarcoidosis. Now, sarcoidosis is less likely as it's more common in females. And it's in this advanced stage of the disease, sarcoidosis would have skin manifestations which are not present in our patient. Also, pulmonary hemorrhage is not a very common presenting feature of sarcoidosis. Bronchial carcinoma with Mets, yes, that is still a possibility. Kikuchi-Fujimoto disease. Kikuchi-Fujimoto disease was discovered by a Japanese scientist, which is autoimmune/infectious disease. It is characterized by peripheral lymphadenopathy. Also, its presentation is usually with bicytopenias or tricytopenias. So our patient did not have any of those. In fact, he had leukocytosis since the beginning and there were no peripheral lymphadenopathies. So that was also very less likely. So, day 9 of admission, the patient's shortness of breath and coughing improved. Currently his vitals were, saturation was 97% at the rate of 1 liter. BP was 126/74, pulse was 90 and respiratory rate had settled down to 23. Now reports came in.
Just interrupt here for
Sure.
the interruption. I just wanted to know all this while what has been the treatment that the patient has been on. Since you did pick up Hawkeye on the initial stain, there was leukocytosis.
Yes.
You then switched to ATT. Were antibiotics continued in this period under cover of which you added ATT?
Yes.
Or there were any
So
changes
antibiotics-
made? What did the patient actually respond to? You're saying that there was improvement.
Sir, I would say that we were continuing antibiotics and antitubercular drugs and steroids were also going on. So our consideration would be that it could be an effect of all the three of those. We don't really know which one it was.
Nothing much changed on ATT, nothing much changed on antibiotics.
Yes, sir.
The addition of steroids that seems to have made some difference.
Right.
Was full dose systemic steroids or how much was being used?
So low dose was started and we were just trying to see what brings the patient some relief. So let's assume that it could be steroids. We don't know for sure.
Yeah, I think when you start multi-barrel therapy, then it's always difficult to pinpoint what is the patient responding to, if the patient responds.
Yes.
Many times the patient doesn't respond.
So actually our thought was that we were going to lose the patient if we don't, use all of our options.
We've been in that, all of us have been in that situation, and sometimes it is more important to treat
Yes.
rather than be too scientific and lose the patient. I completely understand that.
So the reports came in. Sputum for CB-NAT was not detected. Bronchial alveolar lavage for Gram stain, few pulse cells seen. BAL for KOH, no fungal element seen. BAL for AFB, no acid bacilli seen. BAL for culture and sensitivity, polymicrobial flora is grown. So, coming to the day 10 of admission. Mycobacterium tuberculosis, DNA not detected. And this was very disconcerting given that most of us would have assumed tuberculosis, even I, because we've been taught since the beginning that unless proved otherwise, it is mostly tuberculosis, right? So, I would have thought that, I guess. Then, the cell block. Impression, no hemosiderin-laden macrophages were seen. So, that also rules out the possibility of diffuse alveolar hemorrhage and no malignant cells were seen. So, day 7 and day 10, as we can see, there is marked improvement on the X-ray and the aeration of the lung is starting to improve.
Can I make a comment?
Yes.
Like you've been in your differential diagnosis, you've been autoimmune disease has been there from day one.
Yes.
So why have you not done, or why have you not shown the autoimmune markers? What are
Sir,
ANA, DMA, CRP, rheumatoid arthritis? Those were they done?
So there was no history of joint pains and.
But did you do it or not? Number one.
Yeah, they were ruled out, sir. They were ruled out.
So all of them were negative.
Yes, mostly. I will also show it in the future coming slides. But we were hoping to go serial. Like we would first take the biopsy and then.
See, in your differential diagnosis, right from the time when the patient came, or maybe day 3, one of the possibilities was autoimmune.
Right, sir. Now the biopsy came in. It was suggestive of inflammatory pathology and we were expecting a lot from this report as most of our diagnoses were depending on it. So, because the biopsy was suggestive of inflammatory pathology, we decided to re-look for the nodule that we had saw in the vocal cords during the bronchoscopy. So, we ordered a fiber-optic laryngoscopy. So, can you see that there is no nodule anymore? Yeah, the nodule disappeared. Also, the vocal cords, both of them, they seem fine. They seem to be working fine.
What is the time gap between the bronchoscopy and laryngoscopy, and during this time, the patient, as Dr. Saraswat asked, what dose of steroids were given?
Sir, I think 3 to 4 days had elapsed, and the dose of steroid was 2010. 20 in the
This could be
morning.
construed as response to steroids, because
Yes.
in the initial impression you showed us a very ragged, irregular looking vocal cords,
Yeah.
which are quite smooth and glistening now, and the nodules are gone.
Yeah.
So one could interpret this as steroid response.
Yes, definitely. So, multiple cavitary nodular lesions with consolidation, with bronchial hemorrhage, plus minus CNS involvement. So, pulmonary tuberculosis is very less likely since the TB-PCR is negative. Systemic lupus erythematosus, it's still a possibility. Anti-GBM disease, diffuse alveolar hemorrhage was not present, which is probably the most common feature of good pasture. So that has been, it's very unlikely. Bronchial carcinoma with METs, that can
How
also...
do you say that diffuse alveolar hemorrhage was not present? You could not reach the alveoli on the bronchoscopy.
Yes, sir.
Because the large bronchus was so inflamed that the bronchoscopist could not go very well.
Right, sir.
So how do you say that there is no...
So, but also there was no renal involvement, which is renal and pulmonary involvement. So only the pulmonary was present. So we, for the time being, we thought it was less likely.
Another thing.
Bronchial carcinoma with METs was also unlikely, given that there were no malignant cells on the seen on the cell block. Okay, so moment of truth. ANA by IFA was negative. Bal nocardia PCR, RNA not detected. Lyme Borrelia Burgdorferi IgG negative. And PR3 EISA ANCA serum was positive. Not just positive, it was highly positive. So, what is ANCA vasculitis? Now we know that we're dealing with ANCA vasculitis. What is it really? The anti-neutrophil cytoplasmic antibody associated vasculitis, it targets small to medium-sized vessels with sinonasal, pulmonary and renal involvement being the commonest, but virtually it can involve any organ. These diseases are characterized together, and the antigens which the antibodies are directed against are mainly proteinase 3, PR3 and myeloperoxidase, MPO. Okay, so there are two types of ANCA, C-ANCA and P-ANCA. Because we saw earlier that PR3 was highly positive in our case, so C-ANCA most common is granulomatosis with polyangiitis. Others may include Churg-Strauss syndrome, eosinophilic granulomatosis with polyangiitis, drug-induced vasculitis and leucoclastic vasculitis. But because there was no history of asthma or eosinophilia in our patient, so Churg-Strauss was less likely. Drug-induced vasculitis, he had no prior drug history, like drugs like levamisole and hydralazine, allopurinol, etc. could cause it. And leucoclastic vasculitis was also very less likely because there were no skin lesions that were present. So, PR3 or C-ANCA. Proteinase 3 is a single glycosylated protein chain which shows a diffusely granular cytoplasmic staining pattern, as you can see on the screen. Granulomatosis with polyangiitis, it has 90% of ANCA positivity, which is most commonly PR3 positive. GPA without renal involvement has 60% of positivity, and here also PR3 is common. Now, let's reevaluate. The patient's attendants located his old documents, and which included his MRI report, which was suggestive of cerebral venous sinus thrombosis. So, what we have on our hands is a young male with cerebral venous sinus thrombosis, right chronic suppurative otitis media plus lower motor neuron facial palsy, consolidation with nodular and cavitatory lung lesions, and PR3C ANCA was positive. On X-ray PNS here, we can see that there is deviated nasal septum and maxillary sinuses show chronic sinusitis. Mastoid X-ray, mastoid air cells are destructed and there is no clear demarcation. The NCB which was performed earlier, it was suggestive of axonal lesions involving facial nerve on the right side. So, what is the American College of Rheumatology criteria for granulomatosis with polyangiitis, and does our patient fit into the criteria? 3 out of the 6 have to be present. Abnormal urine analysis, we did not have it. Granulomatous inflammation on biopsy, we did not have it. Nasal sinus inflammation, yes there was. Subglottic, tracheal or endobronchial stenosis, yes it was. Abnormal chest X-ray or CT, yes there was. PR3 ANCA or C ANCA staining. So our score out of the criteria was 4/6. The 2022 American College of Rheumatology revised criteria, our score for our patient was 11/17. So final diagnosis, as almost every one of you might have guessed, it's granulomatosis with polyangiitis plus minus CNS involvement. Okay, so what is granulomatosis with polyangiitis? Wegener's granulomatosis was renamed because of Frederick Wegener, who discovered the syndrome. He had Nazi ties and he was an American pathologist. So he was stripped of all of his recognitions and it was renamed to granulomatosis with polyangiitis. It is a clinico-pathologic syndrome characterized by granulomatous vasculitis of the upper and lower respiratory tracts and glomerulonephritis. However, any system can be affected. I would like to quote a study which included 158 patients and it was conducted in National Institute of Health, Maryland, USA, where it states that kidney with glomerulonephritis is affected up to 77%. In ENT, sinusitis and otitis media up to 92%. Lungs with pulmonary infiltrates and pulmonary nodules 85%. Eyes can be involved sometimes. But in other category, CNS, as in our case, it is usually affected at 1% at the disease onset and 8% during the course of the disease. Okay, so now that we have established that our patient has granulomatosis with polyangiitis, next part would naturally be to treat the patient. For treatment, there are a number of variables that have to be considered, like before we initiate the immunosuppressive drugs. So, what is the severity of the disease? Is it a first presentation or is it a relapse? Are there any comorbidities that might affect our patient? Are there any contraindications to immunosuppressive drugs? As well as we need to reference recent publications for any advancement or modification in the drug usage. So to aid the clinician, following scores and indexes were developed which help in assessing the disease activity, out of which BVAS score is of utmost importance in GPA. Rest are used for Takayasu arthritis. BVAS score in our patient is 38 plus minus 3 out of 63, which indicates a mild to moderate disease. The vasculitis damage index is used to evaluate the patient's residual organ damage once he has received the induction of 6 months. Okay, coming to treat the patient, active ANCA-associated vasculitis, non-organ threatening GPA that is localized. Methotrexate plus steroids is preferred. If the patient is in remission, we continue this. If the patient has refractory disease, we consider azathioprine, rituximab or cyclophosphamide plus steroids. In systemic or the severity of the disease, like our BVAS score was 38, our patient fell into the mild or the moderate category. So he was the treatment recommended is cyclophosphamide or rituximab plus steroids. If the creatinine is more than 5.7, plasma exchange is considered. If the patient goes into remission, methotrexate or azathioprine or rituximab plus steroids may be considered. If there is refractory disease, cyclophosphamide or rituximab. Now the question would be what would we prefer, cyclophosphamide or rituximab? So we preferred cyclophosphamide because rituximab obviously has limitations of its use. Also, it will add a cost burden to the patient, and we wanted to keep a reserve drug in case the patient would go into relapse. Okay, so we gave him immunosuppressive drugs and steroid. Oral cyclophosphamide was chosen over IV as compliance is obviously better with oral. And according to published trials, relapse rate has been shown to be lower with oral formulation. This is our patient. These pictures have been taken with his consent. As you can see, the X-ray is starting to clear up, and the bronchoscopy, repeat bronchoscopy, showed that the airways were clear. The patient was discharged after 15 days in the hospital and came back for checkup after 7 days and has been coming back every month in the general medicine OPD. I would like to show you a video of the patient who wanted to contribute to our effort. The sound is a little questionable, it's not there, but I can relate to you what he's saying. Just a moment. He's saying that he's absolutely fine. It has been 5.5 months since he was started on the treatment. He is able to do all of his routine daily activities. He doesn't feel any shortness of breath anymore. And his...
This is the yoga posture you do.
Never mind.
How long do you propose to continue at this level, and how are you going to modulate his immunosuppression in future?
Sir, he is currently in remission, so we would give him 6 months of treatment. Then we would like to switch him to methotrexate after it's completed. And we will also calculate the damage index, which would tell us the residual damage that he still has. And then because he's in remission, so the same treatment would be continued. Okay, so now that we know that our patient is all right, he is recovering, what is the prognosis that has been seen with GPA? So there was a long-term survival of patient with vaginous granulomatosis study conducted in USA, New York. So males over the 12-year observation had a 2-fold mortality and an excess death rate of 25. Survival was poorest in the first 5-year interval. In the next 5-year interval, mortality was 1-fold. No deaths were reported in 11 and 12 years. For females over the 15-year duration, the mortality was nearly 4-folds and an excess death rate of 32 was observed. 5-year intervals 1 to 5 and 11 to 15 were similar. Mortality reduced to 2-folds and excess death rate was about 18. So what we got from here was that as the patient moves on from the 5-year interval, his prognosis improves. Now, because we had received the older documents and it showed us the MRI report of our patient, I would now like to invite Dr. Himanshu Kaushal, Senior Resident 2nd year from the Department of Neurology, to explain to us CVST.
Good morning, everyone. Since the patient was a young patient with past history of CVST and element-type facial palsy, and since we were not able to recollect his films, the report was available that was showing thrombosis in the sigmoid sinus, right transverse and right, and superior sagittal sinus. So let us discuss what is the venous system of brain. It is divided into 2 parts. One is the superficial cortical venous sinuses and the deep venous system of brain. How these are different from peripheral veins? That there are no muscular layer and there are no valves. So it is easy for the infection to spread in these sinuses and to thrombose. So this is same diagram depicted in the MR venogram showing various sinuses. So what is CVST? It is an important cause of stroke in young adults, being common in females and contributing to about 0.5% of all strokes. When it involves the venous sinuses, this is known as cerebral venous sinus thrombosis. When the small feeding cortical veins are included, this is known as cortical venous thrombosis. It is often misdiagnosed or diagnosed late because it mimics other neurological conditions because of its presentation. So, like in our patient, what could be the possibilities? If we encounter a patient of CVST, one are the genetic thrombophilias, second are acquired thrombophilias, hematological disorders, infections, most common inflammatory disorders, malignancies, drugs. So what are the clinical manifestations? The most common clinical manifestations are headache and seizures. Patient can also present with blurring of vision, visual loss, disturbance of consciousness, aphasia, cranial nerve palsies, isolated psychiatric symptoms, hemisensory loss, hemiparesis. So it is a great mimic. Coming to the management of CVST, once we have confirmed that the patient has CVST with clinical suspicion and on MRI, we start the patient on anticoagulation, being it IV heparin or subcutaneous low molecular weight heparin. There are 2 types of patients. One are the heparin responders and second are non-heparin responders. In heparin responders, the condition remains stable and there is neurological improvement. Then we switch these patients to oral anticoagulation. If there is neurological deterioration, we classify these patients as heparin non-responders. And if the repeat imaging shows mass effect, we should consider decompressive hemicraniectomy. If there is mild or no mass effect, then another possible treatment could be endovascular therapy. So duration of anticoagulation, when it is provoked, it is 3 to 6 months. When it is unprovoked, 6 to 12 months. And when it is recurrent because of thrombophilias, we can need lifelong anticoagulation therapy. And anticoagulation includes vitamin K antagonist and novel oral anticoagulants. Now I would like to invite Dr. D.P. Bansal sir to further take the discussion on review of literature.
So no literature is available. Patient having a GPA with CVST, that confused us from start. No text available, no review of literature available for CVST in this case, or CVST was there. So we gone through some literatures that shown. There is an article, there is dermatology in the sample size by 35 that is published in the 2014. And we have already seen that the serious involvement in any case of GPA was only 1%. But mostly there is an involvement in the form of cranial neuritis, multiple cranial neuritis, and most commonly there is a second optic nerve is involved, then followed by the 6th, 8th and 9th and 11th basal part of the brain is involved. Or there is a meningitis, pachymeningitis, spinal meningitis, pachymeningitis, or there is a ischemic stroke is there. In this case also they have shown like this. In any of the type of ANCA vasculitis, there is a arterial involvement or the venous involvement. ANCA, if there is ANCA associated vasculitis, most commonly there is thrombosis seen in the large cells, large cells vessels vasculitis like the Giant cells vasculitis of the Takeshita arthritis, or some cases of the Behçet's disease. They have published the data. They have a such type of venous thrombosis. So venous thrombosis is also common in the ANCA associated vasculitis rather than arterial involvement, but mostly there is seen in the MPO type of P-ANCA vasculitis. And there is a second report that I have shown that there is a hypertrophic pachymeningitis with CVST. How the mechanism could be occurs in the GPA case presenting with CVST? It could be due to the idiopathic hypertrophic pachymeningitis, because pachymeningitis one case report is available only on the internet. That's showing that there is a pachymeningitis, there was a pachymeningitis and that was encompassing the venous sinuses. That's why there is obstruction of venous sinuses that resulted into CVST. Second, itself, vasculitis may cause venous thrombus, that is systemic inflammation, and along with the thrombotic association, there is a close relation between two. Third is infection. Any infection may cause this type of CVST, but our case have responded with the anticoagulants. There was no antibiotic was used previously 2 years back. So procoagulant state maybe because there was hyperhomocystinemia. So there was no case report that suggestive of hyperhomocystinemia CVST in GPA. And there was another case that have shown that there is a hypertrophic pachymeningitis was associated with the MTHFR mutation. So it could be possibility of the MTHFR mutation leading to the hyperhomocystinemia, and then there is thrombosis in the form of CVST. So hyperhomocystinemia is also, there is a case report of in India from the PGI Lucknow. They have concluded a study with the hyperhomocystinemia and CVST. They also shown there is a 50% cases have CVST caused by the hyperhomocystinemia, out of which 30% was MTHFR mutation, and collectively there is a MTHFR with hyperhomocystinemia. There are 40% cases. So there will be a strong association between two of them. Second rarity in our case, that is a pathological vaginous granulomatosis with facial nerve palsy. Usually pathological involvement seen in the 40% cases of the GPA, but simultaneously presenting with the facial nerve palsy was seen in the few case reports. There is only case reports available. There is a no long case series data is available from India. There is a 2 or 3 case studies that have shown. One of this is a sample size 60, and there is a from South India, and most of these cases presented delayed with renal involvement. Usually these cases detected with upper way, lower way, and renal involvement. In our case, there is no renal involvement was there. Now, recent advance in the treatment what shows that etanercept and TNF alpha are two inhibitors. It stopped the trial, the WA trials, due to the so much efficacy in the remission phase of the maintenance phase of treatment. And altacept is going on trial. Valimumab, there is the monoclonal antibodies, the leukocyte stimulator. And the fourth one is the valimumab or AVAP1, anti-C5A, that is used, that should be used in the, as an induction agent, and it is undergoing the FDA approval. This is the trials. So, a young male with intractable cough, after exclusion of common causes, we should always consider for the other rare entity as a vasculitis. And early diagnosis obviously lead to better prognostic outcome in any case. But in this case, we see that there is a tuberculosis is common in India, and usually basal tuberculosis, basal dermatitis cases are treated as a TB, and they come later on with renal involvement. After the renal involvement, the prognosis is poor. So this should be diagnosed earlier. Antiplatelet and anticoagulants, most of the trial and text says they have limited role, except in CNS ischemic stroke or some venous thrombosis. Otherwise, there is no role of antiplatelet and anticoagulants, along with immunosuppressant. Without immunosuppressant, any thrombosis or ischemia cannot be reversed. Multidisciplinary cooperation is always key to desired patient care and help us to diagnose better together. So, in the last, I think the turning point in this case was the bronchoscopy. In the bronchoscope, we find out and set in mind that there may be some most likely autoimmune pathology. And so I like to highly thanks to respiratory department who help us to reach the diagnosis, and Department of Neurology and Department of Radio Diagnosis, and a special thanks to the management people for providing us with an excellent platform. And learn better together, and to the review committee for their invaluable supports. They really help us to make this presentation worthwhile, and a big thanks to our patient also who help us to put their input and made this presentation.
Mahatma Gandhi last year was a patient who was put on ATT for empirical indications without a justified diagnosis. And if you look at the daily literature from the liver point of view, the most commonly suggests that unless we have convincing evidence of either getting the AFB is very difficult, granulomas on histology, or now with these microbiologic techniques.